Hello, my name's Ian McConaughey and I'm going to be delivering 3 lectures on cardiology. This is the first, therefore, and the learning objectives that we're hoping to get across within this time are to identify the symptoms and signs of heart disease, which would include murmurs and nature of shunts, and to look at specific conditions as noted on the slide. So, turning to the first question, question 1. A 2-week-old girl presented with apparent heart failure. Which of the following are true regarding heart failure in infancy? And I'll pause to let you have a look at the questions and the options. Congenital heart disease can be associated with heart failure in infancy and may present with either failure to thrive or in the very early neonatal period as excessive weight gain. The signs include breathlessness, particularly on feeding or exertion, sweating, poor feeding and recurrent chest infections. The pulmonary venous congestion in infancy means that the compliance of the lungs is increased, hence the tachypnea and respiratory distress. Grunting is an attempt by the child to maintain the end expiratory pressure within the lung, i.e. trying to avoid collapse of the lung. Difficulty in feeding is found owing to the fact that it's difficult to swallow and breathe at the same time. Hence, if you are tachypneic, you're going to have difficulty in being able to easily and readily feed. The feature of recurrent chest infections being characteristic is due to the fact that there is increased fluid within the lung, and this may mean that clearance of lung secretions may be inhibited. The right venous congestion is typified by hepatosplenomegaly, much more commonly just liver enlargement itself. It's frequently difficult to be able to see the external jugular vein, and particularly in well-covered young babies may be impossible. Having said all this, it's essential to think about other causes such as severe anemia, respiratory illness, or other associated infections which may be concurrent with heart failure or can give a similar picture. So, to recap, the signs that are associated include poor weight gain or failure to thrive, or in the neonatal period, excessive weight gain, tachypnea, tachycardia, heart murmur, and this may also include the presence of a gallop rhythm. There may be cardiomegaly, there may be hepatomegaly, and cool peripheries. Turning now to question 2. Cyanotic heart disease. And again, there's a list of options here for you to determine whether or not cyanosis is present. I'll pause to allow you to consider your answer. It's important to emphasize the difference between peripheral cyanosis and central cyanosis. Peripheral cyanosis, i.e. blueness of the extremities, can occur if you come in from the Arctic wastelands or Siberian tundra without your mittens on, i.e. it is not due to an abnormal heart with shunting. Central cyanosis, as you are well aware, is when you look to the mucous membranes such as the tongue and see a blue colour. This is obviously associated with an increased deoxygenated blood level of hemoglobin. Central cyanosis can only be seen if the amount of reduced hemoglobin in the blood is greater than 5 grams per deciliter. So may not actually be visible if the child is profoundly anemic. Persistent cyanosis in an otherwise well child is almost invariably a sign of shunting. Cyanosis in a newborn infant with respiratory distress can be due to not only cardiac disorders, but also respiratory disorders such as surfactant deficiency, meconium aspiration, pulmonary atresia, and so on. Another cause includes persistent pulmonary hypertension of the newborn, when there's a failure of the pulmonary vascular resistance to fall after birth. Cyanosis may also be seen due to significant septicemia, such as with group B streptococcal infections, can be seen with inborn errors of metabolism, and due to polycythemia. To reinforce the answers, the common left-to-right shunts include atrial septal defects, persistent ductus arteriosus, PDA, and ventricular septal defects, VSD. Cyanotic conditions includes tautology of Fallot, transposition of great arteries, and a complete atrioventricular septal defect. That is to say, there's such an extensive lesion that there is common mixing at atrial and ventricular level. Left to right shunts are associated with increased pulmonary blood flow, so the child is pink. Right to left shunt means there's transference of desaturated blood to the left side of the circulation, hence central cyanosis may be seen. Eisenmenger's syndrome, which is noted, can occur due to prolonged increased pulmonary blood flow in the lung, causing, as noted, medial hypertrophy of the medium-sized pulmonary vasculature. This increase in the muscle bulk of these pulmonary arteries can lead to pulmonary hypertension and the reversal of the shunt direction. That means to say that conditions such as VSD, ASD, and even PDA, albeit rarely, can become cyanotic when Eisenmenger syndrome is present. Ordinarily, however, these three lesions, the VSD, PDA, and ASD, are considered to be left-to-right shunts. Moving on. Question 3. 4-week-old baby presents with poor feeding for 2 days. He is pale with poor peripheral perfusion. Which of the following is the most single reliable clinical feature to diagnose coarctation of the aorta? Coarctation of the aorta represents a narrowing of part of the aorta. This may vary in length, and considerable portions of narrowing of the aorta can be termed interruption of the aortic arch. It's important to note that the site of the coarctation of the aorta can be anywhere along the aorta. Hence, a number of lesions may occur before the branching of the vessels to the left subclavian. I will talk more about this in a subsequent lecture. It should be realized, though, that this means that the right radial artery should be used to palpate with either femoral arteries, as if the obstruction occurs in the arch of the aorta before the vessels branching to the left subclavian, if the left radial artery is palpated and compared with the femoral arteries, there may be no radiofemoral delay. The presentation may occur early in the neonatal period, known as critical coarctation, or can present later in life as a manifestation of hypertension. Turning to diagnose coarctation of the aorta, the most reliable sign, as indicated on the slides, is about palpating femoral and radial arteries. Practically, forelimb blood pressure measurements can be difficult, and although suggested and is starting to be used as a screening technique in certain Scandinavian countries, the use of pulse oximeter can be fraught. Auscultation at this age may not necessarily reveal very much, and the rib notching associated with coarctation of the aorta represents a prolonged increased volume of blood flow through the collaterals, over which then the ossification of ribs occurs. That's to say there's not an erosion of the rib, but simply that the rib, initially in its cartilaginous form, and then when it becomes ossified, grows around the expanded vessel. Question 4. A 1-year-old girl is noted to have an atrial septal defect. Which of the following features suggests that there is a large to moderate shunt? ASDs are common acyanotic conditions and occur frequently in the exams. There are 2 types of atrial septal defect. There's the secundum, which accounts for the majority of ASDs, approximately 80%, and the relatively less common partial atrioventricular septal defect, otherwise known as primum ASD. The secundum defect is a defect in the centre of the atrial septum involving the foramen ovale. The partial or primum ASD is a defect of the atrioventricular septum. Generally speaking, when talking about ASDs, the former, that's to say the secundum ASD, is generally considered. The clinical features, there may be none, there may be recurrent chest infections, heart failure can occur, and there may be an increased incidence of arrhythmias, said to occur from the age of 40 onwards. Characteristically, there's a fixed and widely split second heart sound. This is due to the fact that the atria act as a single chamber and therefore fill left and right ventricles proportionately. As you know, filling of each ventricle has to be complete before it can eject, and therefore there are relatively fixed amounts of flow going to left and right ventricles, which is maintained. Hence, they are fixed. Moving on to question 5. Turning our attention to VSDs, another commonly encountered condition in the exams, and the most common cardiovascular congenital defect. The question is, which of the following are true regarding a child with a large solitary VSD? I'll let you have a think about these questions. VSDs may be classified as being membranous or muscular. Muscular being down towards the apex of the heart, membranous being up towards the endocardial cushion area. The former, muscular VSDs, have an increased incidence of spontaneous closure. The membranous VSDs, when they close, may cause distortion to the local anatomy. The symptoms and signs that are seen depend on the amount of shunting that occurs across the ventricular septal defect. This means that for many small VSDs, children may be relatively asymptomatic, and these may close spontaneously, particularly, as mentioned before, if in the muscular area. Small VSDs may have a thrill at the lower sternal edge, a pansystolic murmur, best heard at the lower left sternal edge radiating out to the apex, and may have a quiet pulmonary second sound. Chest x-rays in small VSDs are usually normal, and as said before, most of these close by themselves. Large VSDs may present with heart failure and breathlessness. They may also present with recurrent chest infections. The signs that are seen may include a soft pansystolic murmur or no murmur at all if there's a very large movement of blood without turbulent flow. There may be an apical mid-diastolic murmur because of increased flow across the mitral valve and a loud P2. As mentioned before, the signs of heart failure may be seen. Moving on to question 6. Patent ductus arteriosus in preterm infants. This question asks you to consider the signs and symptoms associated with patent ductus arteriosus. The ductus arteriosus connects the pulmonary artery to the descending aorta. At birth it closes owing to increased oxygenation and to the pressure changes within the lung, meaning that more blood is diverted to the lung fields, hence there's decreased flow across the ductus arteriosus. In preterm children, therefore, who have persistent ductus arteriosus, there's an increased flow to the pulmonary vascular bed. This may present with a delay in extubation of premature babies who are on ventilators, or apnea. The increased blood flow also affects the compliance of the lung, and hence there may be an increased susceptibility to chest infections. This, of course, is a left to right shunt and therefore is not associated with cyanosis. Question 7. The recognised features of transposition of the great arteries are, and a selection of options are given. Transposition of the great arteries means exactly what it says. That's to say that the aorta comes off the right ventricle and the pulmonary trunk, main pulmonary trunk, comes off the left ventricle. There therefore has to be a connection between these two circulations. This may be either by means of an ASD or VSD, in which case the child may present with cyanosis, or can present with a PDA, which, when it closes, means that there is no communication between the left and right side of the circulation. This obviously leads to a life-threatening condition and death if no remedial action is undertaken. That is to say that the TGA, in this case, is a duct-dependent condition. Hence, the routine procedures of ABC, airway, breathing, circulation management must be followed, and a prostaglandin infusion established so as to open up the duct again. In this scenario, an atrial balloon septostomy may have to be attempted in order to create an ASD, that is to say, allowing a communication between both sides of the circulation. Question 8. Children with these conditions should be given antibiotic prophylactically before dental procedures. And here is a list for your consideration. I'm sure you're somewhat surprised by the answer. However, the guidelines published in 2008 by NICE no longer recommended routine administration of antibiotics, even for those who'd had previous episodes. I've included here the website for you to look in detail at the reasons behind this important change in recommended practice. Don't forget, however, that if there is forceful pressure on any part of the endothelial surface, this may become breached, and hence this area can then be a nidus for the subsequent development of infection and the ensuing development of infective endocarditis. Question 9. Left to right shunt usually occurs in, and then a range of options are given. Key points again about left to right shunts, as noted, that is to say, they're common to all the septal defects and to PDAs. Of interest, coarctation of the aorta is associated with VSDs in about 20% of cases. Fallow's tetralogy, which we will come to in greater detail in a subsequent lecture, shunting is from right to left owing to pulmonary infundibular stenosis and spasm. That is to say, shunting occurs in a spelling episode when a cyanotic condition is seen. Okay, question 10. A 17-year-old boy presents with palpitations. His physical examination is normal except for a systolic murmur in the second left intercostal space and prominent precordial motion with a late second systolic impulse. Which of the following conditions is he likely to have? Well, the most likely condition in this setting is that of HOCM, that's to say, hypertrophic obstructive cardiomyopathy. This can be inherited as an autosomal dominant condition and can be associated with arrhythmia and sudden death. Interestingly, athletes are now routinely screened to ensure that they're not at risk of either having a congenital form of HOCM or going on to acquire a version of HOCM by virtue of their increased exercising, as hypertrophy of heart muscle can occur. This type of murmur is not commonly heard in the other conditions. So, to summarise, the topics that we've covered in this lecture include the signs and symptoms of heart failure, cyanotic heart disease, coarctation of the aorta, ASD, VSD, PDA, TGA. We've talked briefly about dental prophylaxis and left to right shunts. Thank you for listening.